Okay, well, I'm one of the leads in the Medicines Optimisation Innovation Centre here in Northern Ireland and one of the principal pharmacists in the Northern Health and Social Care Trust. And I suppose my key function is to drive innovation in medicines use. And we do that through a whole range of activities, through research, quality improvement, service development, technology, knowledge exchange. And we work closely with a lot of collaborators in healthcare, industry, in academia and community and voluntary sector. And we engage a lot with colleagues across Europe. So very much tapping into the ethos in Northern Ireland of test, scale and spread. Well, I suppose if you think back to the beginning of the pandemic, the issue was that there was a global emergency, that healthcare systems worldwide were doing their utmost to try and scale up and to increase their resourcing and capacity in order to manage the pandemic. And medicines, as pharmacists, we know are key to the healthcare response. And we know that because of the increase in demand for healthcare, there was an equal increase in the demand for medicines, and a lot of those in critical care. And one of the biggest issues, I think, in this kind of a pandemic is that the supply and demand is very complex, because you've got a massive increase in demand because it's global, and also there's a degree of urgency generated because in healthcare people are wondering where the medicines are going to come from, and they know the people coming into their ICUs and where the medicine's going to be available or are they not. And we know that in the media they captured a lot of that and a lot of media attention around where medicines to help ventilation were going to come from. So that was, I suppose, the key problem, and that just generates further pressure on already constrained resources. Well, I suppose we were starting with a blank page because it was a new virus, it was a pandemic, and we had very little to go on. So one of the things that we wanted to do was make sure that we had a process to estimate these critical care drugs and how much and how many would be necessary for individual patients and for the wider healthcare system as a whole. So what we set about doing was having a collaborative approach across sectors, within pharmacy, across healthcare professionals. And what we did was identify, first of all, the requirement of the critical care drugs. And once we had identified the requirement per patient, then we were able to look at some of the real world data that was becoming available. Remember, this was an evolving situation, and nearly on a weekly basis more information was becoming available. So we used real world data available from Northern Ireland, from ICNARC, which is a UK-wide intensive care national audit and research centre. We also looked at data that was available from elsewhere in the UK, and we also had available to us an unpublished tool that was developed by colleagues in England, Mark Borthwick and Barton et al. And they developed a tool way back in 2009 for the H1N1 swine flu pandemic. And what they did was put forward a series of assumptions that were helpful to us in our work and in our modelling. So, for example, they made assumptions around the proportion or the percentage of intensive care patients who would be likely to need a particular drug within a particular therapeutic class, together with an estimated duration of therapy and for a typical ICU length of stay. So all of that was used together to develop our model. For example, if I give you maybe the neuromuscular blocker group as an example, because that made a lot of worldwide headline news, because if we don't have enough neuromuscular blockers, then we can't ventilate patients, and there was a lot of concern. It's like having a car without petrol, and a lot of very worried clinicians on the ground. So for example, if we think that maybe around about 85% of patients in ICU would need a neuromuscular blocker, and they're likely to need that maybe for a period of 7-8 days, for a typical ICU length of stay of around about 12 days. But within that category of neuromuscular blockers, we've got a series of different drugs. So for example, we've got cisatracurium, rocuronium, and atracurium for some examples. And within that class, then we can identify in Northern Ireland which of those neuromuscular blockers was designated first line. So we estimated, for example, in Northern Ireland, around about 70% of patients who required a neuromuscular blocker would in fact use cisatracurium, and then next around about 20% would need rocuronium, and the remaining 10% atracurium. So that then allowed us to build our model based on assumptions, based on the first line, second line, third line choices within Northern Ireland. And that allowed us then, with the tremendous support of colleagues, to map our requirements for the current situation and for any potential surge, because bearing in mind we didn't know how big the surge was going to be, but with this type of model we can tap in any figure, 90, 180, 360, and then that gives us the output as to what the requirement would be. So that then the requirement was matched against the available stock within trusts in Northern Ireland and the wholesaler stock. So it was very much looking at the supply and the demand that we needed within Northern Ireland. That then allowed us to work out what our current capacity was. So for example, the work contributed to an acute care work stream where the availability of drugs was RAG rated against a red, amber or green rating. So when we looked at the individual drug components, if we had more than 14 days worth supply, then that was a green rating. If we had somewhere between 7 and 14 days, that was an amber rating. And if we had less than 7 days supply, that was a red rating. So that very much allowed us to look at the capacity that we had within the system. So there were no surprises, because in healthcare, we don't want any surprises. We wanted to know as well as we could and as accurately as we could what capacity we had within Northern Ireland. It worked really well, and I suppose we don't want to run out of things, and with this kind of model that we can monitor and we can plan, we knew in advance where we were and what our capacity was. So that meant there were no surprises. And it also meant that if our stock was starting to become constrained, then we knew what our second line was and the capacity that we had within that second line and third line. And the advantage of that is it means that we're reducing risk. Because if we have, for example, a situation where a drug is constrained and there's not enough within the supply chain, we don't want on the ground rapid changes in drugs or in doses, because we know it's not safe. Whereas we were able to plan and mitigate against that. So I'm happy to say there were no surprises. And I think a lot of that is down to this type of work, which allowed the oversight and the governance and the planning and of course the communication with the teams. Well, again, we don't want sudden shortages, and because we did a huge amount of work with the regional pharmaceutical procurement service, linking with the manufacturers and the wholesalers, we knew what capacity was there in the available stock. So there was no running out or no immediate shortages. It was all planned. And I think in healthcare, that is precisely what we need. When there's potential chaos and potential over-ordering of organisations and that vicious circle that we mentioned earlier, it means if we have this type of model and this type of process, then we know where we are and we know what's coming in terms of availability and capacity. It absolutely can, and we've done a lot of work already in palliative care, because a lot of these drugs that are used in intensive care are also used in palliative care. So we've already done a lot of work around the drugs and the doses and the percent uptake and first line, second line, third line choices, and that's already been agreed and endorsed by our regional palliative care group. So that's already done, and we're also looking at work in theatres, because again, some of these drugs are used in theatres, and the same type of work potentially could be applied to different types of procedures, maybe major, complex, major, and so on, to identify capacity. So it absolutely can, and I suppose anywhere where we need oversight and we need monitoring and we need to keep a handle on what's happening, this type of work absolutely would work. Well, I think we start off with pharmacy and pharmacists. I think the learning from this is that we are an adaptable profession with a huge amount of skill and knowledge that can be plugged in to a lot of gaps in the system. And certainly this is a piece of work that wouldn't traditionally be a pharmacist role, but was absolutely critical in how the planning and preparedness was navigated in Northern Ireland. And I think one of the comments from one of the groups that was involved in this was how well pharmacy and pharmacists within Northern Ireland work together for the greater good. There was never a sense of one organisation or one trust trying to grab more stock. It was very much we're in this together. And I think pharmacy and pharmacists are immense advocates of working together for the shared goal and the shared good. So I think that was just a real reinforcement of pharmacists. And also for other organisations, wholesalers and suppliers, I think that the key element and the key success of this piece of work was that it was collaborative and it was a partnership approach, and it was including all of the relevant stakeholders. And I think there's key learning in that, and that's how this type of work can be successful.